thrilled that you're all here today and that we are here with you for the second webinar of our Innovation in Progress series. And just a quick note before I advance this slide, you can see the URL at the bottom of this page, painmanagementalliance.org/innovation-webinar-2. And that link, you will find the slides that we're going through today if you care to follow along, and they'll be there later along with the recording when it's ready. So I am Amy Goldstein. I'm the director of the Alliance to Advance Comprehensive Integrative Pain Management. And I'm just going to spend a couple minutes talking to you, and then we're going to turn over to these wonderful panelists. So why this webinar today? So the use of integrative care has been increasingly recommended by policymakers everywhere. And most clinical, pain-related clinical guidance points to the early use or first-line use of non-pharmacological and team-based therapies, but extensive challenges affect coverage and access, and especially for people who are underserved. People with pain want access to these therapies, but there continue to be deep disconnects that are around misperceptions, current research, clinical practices, business case, and more. Awareness and advocacy is a key lever for change, and we believe that through connecting different stakeholder perspectives around shared interests that we can bring improved awareness and spark more advocacy opportunities. So today we'll be doing that with some fabulous panelists, and we'll do quick introductions as they each speak to keep things moving, and so we have time for Q&A at the end. An important note, your expertise really matters. One thing that we value so much about this alliance is the fact that we bring together more than 75 stakeholder organizations and many different perspectives. It would be easier, honestly, if we didn't, but this is why we exist, because it takes more care to bring together different perspectives, and we do it with the connect of people with pain at the center of everything. And so you can also see the list of our participants if you're interested on our website. But because this particular webinar is only a small piece of all the different perspectives that matter in our work, we're going to do a quick pre-webinar poll just to ask you what attracted you most to this webinar. And if any of the automated answers don't kind of fit, why, please use the chat feature to share your other answers. We will capture them and use them in our input. So now for the poll. Terrific. So looks like we have some varied interests. Update on research for integrative therapies, 40% perspective from a payer, new program for Medicaid population, learning more about brain research related to chronic pain, learning more about clinical aspects for pain management, and then other in the chat we'll look for. Thank you. So quick words about AAC-IPM. So it is not an organization. This is a nimble grant-funded initiative. It's a multi-stakeholder collaborative, and we connect people with pain, payers, purchasers, many different providers, academia, government agencies, advocates, and more. And again, as I said before, we align around keeping with people with pain at the center. We focus on connecting the dots to advance an equitable, whole-person, multimodal, guideline concordant care. And some of the ways we do that is through strategic digital communication, policy advocacy, education and awareness, and coordinated responses. And I will just mention very briefly, just related to coordinated responses, a recent success story that some of you on this call today also participated in, advocating for integrative pain care at the federal level. So their CMS put out its physician fee schedule 2023, and we responded to that public comment. We organized an effort to get our perspectives together among this alliance, and we put together a coordinated group response that resulted in codes and a number of things that that were taken into account in our group letter. You can read all about it if you want at these links and on our website, and there are now two new codes that we believe will have an impact on integrative pain care that you can learn more about. And just a quick comment on this is advocacy had a vital impact. So without collective advocacy efforts, the well-intentioned CMS codes would have been riddled with unintentional negative consequences. So these are very they may seem complex, but actually simple ways that you can really be engaged, because now with the new codes, we need to make sure people are aware of these and use these so we can collect data and figure out what people with pain will need and have access to. And also sharing your stories and collecting your experiences is vital, because it's through those pieces of input that we were able to create that kind of a response. A special thank you to the primary funder for this alliance, the David and Laura Lovell Foundation. And another special thank you to the fiscal sponsor for this project, the Pain Community. Why do we need AACIPM at all? Just on a quick high level, chronic pain is the #1 cause of disability globally. 1 in 6 Americans live in pain every single day. The costs are astronomical. We believe the $635 billion in expenses is way underestimated, as that number's been around quite a long time. And multimodal care is the gold standard, but simply not accessible for so many people. We have created a CIPM toolbox, and this I figure may be hard to read. I realize it's small. You can download it and look at it at your leisure. But what's important to note about this toolbox is it has person with pain at the center, and then it includes examples of different therapies that fall into different categories that are restorative therapies, complementary and integrative health, behavioral health approaches, medications, interventional approaches, and digital technologies. And a quick nod that those topics outside of digital technologies all mirror the topics that were in the HHS Pain Management Best Practices Task Force report. We added digital technologies because there's just so much momentum there. We felt it was important to include. And this also shows the biopsychosocial factors, some of them, of course, that have such an impact on the ability to provide and access this kind of care. We hope you might enjoy sharing this or seeing this and helping use it in a variety of situations. And we touched on challenges. There are many challenges. That why is evidence-based, guideline concordant, multimodal care inaccessible for so many? And equity issues are a pillar across all of these different challenges that exist. We're going to talk about some of these challenges today through people's discussions, and there's more you can read about with these on our website. So now, without further ado, I want to jump into our panelists. And I would like to introduce Dr. Dan Claw. He's the director of the Chronic Pain and Fatigue Research Center at University of Michigan. So off to you, Dan. Thanks.
So you're doing the slides? Next slide.
Yes.
Next slide. So my disclosure slide and the next slide. So there's 3 different dogma that have been around in the pain field for quite some time that I think the data and the evidence is really changing the way we think about these things. And I'm just going to really quickly talk about all 3 of them. The first is the directionality of the relationship between pain and cognitive factors like catastrophizing or affect, anxiety, depression. I think historically people have thought that catastrophizing and negative affect comes first and that pain comes second, but there's a lot of data now that are suggesting that in many cases, the catastrophizing, the anxiety, the depression occurs because individuals have chronic pain. And if you make their pain better, their catastrophizing and a lot of their other comorbidities get a lot better. Take on the notion that, again, believe it or not, until about a decade or so in the International Group of Pain Researchers, there was still this feeling that in order for someone to have pain, you either had to have ongoing peripheral nociceptive input or damage in the periphery or nerves, but I'll talk about this third mechanism of pain, central sensitization or nociplastic pain. And then finally, this organization knows this well, but a lot of therapies that used to be thought of as being either complementary or alternative because they were really second or third options have really moved into the forefront as we look at the evidence and data for these non-pharmacologic therapies. Next slide. Next slide.
Sorry.
Next.
Oh, okay, there we go.
Okay. So I'm just going to show a couple studies here. This is a study done in individuals getting knee replacement surgery. And knee replacement surgery is one of the few things we can do for people with chronic pain that by and large makes a lot of people a lot better. And this was a study specifically looking at what happened to people's catastrophizing scores when you did knee replacement surgery. And if you look down into the results, what they found is that a sizable number of individuals that were high catastrophizers went down to being low catastrophizers after they had their knee replaced. And there was a really strong relationship between the amount of improvement in pain that people had and the amount of decrease in catastrophizing that they had. Next slide. And then in another study done by Yvonne Lee, again, in rheumatoid arthritis, we have actually really effective drugs to treat the inflammatory component of rheumatoid arthritis. And this was another study that showed in the rheumatoid arthritis patients that had high catastrophizing that were treated with some of these drugs, many of them had fairly pronounced improvements in catastrophizing as a result of getting these therapies. Next slide. This is a study that was done by our group. Chelsea Kaplan led this. This is mining the big ABCD study that's going on in the United States, looking at newly incident mental health disorders in adolescents. And it turns out there were just enough questions about pain in this study that we've been mining this study for children that have new onset of multi-site pain, i.e. fibromyalgia-like pain. And this was really, I think, a pretty amazing study. And what it showed is that these kids who at age 10 entered the ABCD study, they had to be entirely healthy when they were age 10 when they entered the study. In the individuals that entered that study healthy at age 10, who the next year did develop new pain in 3 or more sites of their body, when we looked at their brain images while they were age 10, while they were still entirely symptom-free, the kids who were going to develop new fibromyalgia-like pain had a lot of the same abnormalities as we see with adults that have conditions like fibromyalgia and connectivity. Next slide. And this is a study that's not actually published yet. It's accepted for publication. This was looking clinically at these same individuals. And what we found is that in these kids, again, that were on their way to developing new pain, that the baseline presence of a mood disorder did not in any way predict the subsequent development of new pain, but female sex, sleep problems, memory problems were in fact fairly strong predictors of the subsequent development of pain. And again, in this study, we only saw that mood got worse in these kids after they developed pain. We rarely saw in this study that the problems with mood actually predated the pain problems. Next slide. So this is something that our group's done a lot of work in. These conditions that used to be called central sensitization are now referred to as nociplastic pain. Next slide. You see this table here that until, again, 5 or 10 years ago, the International Group of Pain Researchers really thought there were 2 pain descriptors or pain mechanisms, nociceptive and neuropathic. There either had to be inflammation or damage in the periphery, or there had to be damage or entrapment of a nerve. But again, a lot of evidence, science led to the International Group of Pain Researchers a couple of years ago formally voting that there was a third mechanism of pain. I don't like the term, we don't like the term nociplastic, but we're stuck with it. And this kind of pain is pain that seems to be coming from the brain or the central nervous system instead of from the nerves or from peripheral tissues. And you see down at the bottom right there that some of the classic nociplastic pain conditions would be fibromyalgia, IBS, headache, temporomandibular disorder. But a point of emphasis is this kind of pain very often co-occurs with both neuropathic pain and nociceptive pain. So for example, about a third of individuals with autoimmune disorders or cancer or conditions like osteoarthritis that clearly start as nociceptive pain, about a third of those individuals also have prominent central sensitization or nociplastic pain. And when that occurs, they're going to respond to different types of therapy. Surgery isn't going to work as well. Opioids are not going to work when the pain is coming from the brain. Next slide. And again, you're going to start to see these terms more. This is a review article in Lancet that talked about nosoplastic pain. And one of the interesting things about nosoplastic pain is these individuals are not just more sensitive to pain. I've been using an analogy for decades that the problem with this kind of pain is that people have an increased volume controller, an increased amplifier setting. But they don't just have an increased amplifier for pain, they have an increased amplifier for the brightness of light, the loudness of noises, odors, and brain regions like the insula seem to really be critical brain regions in causing individuals with this kind of pain to be sensitive to a number of different sensory stimuli. Next slide. Another term you hear more and more now is chronic overlapping pain conditions, and these include conditions like fibromyalgia, irritable bowel, temporomandibular disorder, headache, where we really think these are largely sort of the same fundamental problem, that the pain is just literally presenting in different areas of the body. But the major pain type for these chronic overlapping pain conditions is nosoplastic pain. Next slide. And then finally, the notion that we should think of some of these non-pharmacologic therapies, especially the ones that originated in Eastern medicine, as either being complementary or alternative rather than mainstream. I've tried to teach everyone now that these are not the right terms to use. You should use the term integrative, that it actually is sort of disparaging to these therapies to continue to act as though they should be complementing or alternative to things that actually don't work very well, that we use a lot in Western medicine. Next slide. This review is done every couple of years. It's a really excellent evidence-based review, and it took on non-pharmacologic therapies. And just in a 2-year time, this most recent review changed fairly significantly. Next slide. To say that the interventions, that there was evidence that they improved. Can you advance all the way? Look at all the therapies that have been shown to be effective, and just advance the slide. For low back pain, exercise, psychological therapies, laser therapy, mindfulness, acupuncture, yoga. And what you find is that for these non-pharmacologic therapies, when they are studied in almost any chronic pain state, they work. It just turns out that low back pain has had the most research done. So there's more of these therapies that now show up on the list of being shown to be evidence-based in low back pain. But we shouldn't really have the burden be that every one of these therapies has to be shown to be effective in every type of chronic pain, because again, when they are studied, they almost always work regardless of where the pain's coming from. Next slide. And then just keep advancing through the next slide. It's just another list of, again, where the evidence is now, but it keeps improving dramatically. Next slide. So what that report really concluded is that the therapies that weren't yet shown to be effective in some of these different chronic pain conditions, it's largely because they haven't been tested in appropriately powered trials, not that they were tested and shown to be ineffective. Next slide. And this is just to show a JAMA article I wrote on fibromyalgia in 2014. Now, as I show the slide from this, all of those therapies that are now in modest evidence used to be in weak evidence just 3 or 4 years ago. So again, this has really been quite an advance scientifically with respect to how effective and efficacious a lot of these non-pharmacologic therapies are. Next slide. And you'll see here that in the VA and the DoD health centers in the United States, these therapies are all reimbursed now. And again, other third-party payers like CMS are trying to catch up. But again, the VA and the DoD are really ahead of other payers with respect to understanding how helpful these therapies are and really trying to make as many of them as possible available to people that are VA or DoD getting their care there. Next slide. And so our group, in the last couple slides, spends a lot of time, Dave Williams and our group, developing websites to put out to try to help people improve their self-management. The first one was called FibroGuide. We actually tested FibroGuide in our randomized controlled trial, and it worked better than any of the approved drugs for fibromyalgia. And I'm not suggesting that those drugs aren't helpful. I'm just suggesting that these non-pharmacologic therapies are really helpful to use in addition. Next slide. The new version of this is called painguide.com. It's free. I really recommend that you use it with your patients. We're developing derivatives of this. We've developed derivatives of this specifically for individuals with sickle cell disease, lupus, long COVID, And basically, we just put these up there, and they're now being tested in a number of NIH-funded trials. We think that these websites and apps, along with health coaches and things like that, to give people access to the therapies, are really ways that we should be trying to get more and more people access to integrative therapies. Next slide. And then just, again, this just shows some of the different functionality in Pain Guide. We try to keep adding more and more of these non-pharmacologic therapies. You see there, acupressure, but things that people can do with respect to self-management on their own. Next slide. And that's it. Thank you.
Thank you so much, Dan. That was terrific. And we'll have questions and Q&A at the end after we listen to our other panelists. So now I would like to introduce Bethany Rains, who's a research scientist, and we'll be talking more about pain in the brain. Bethany?
Yes, hello. So I'm Dr. Bethany Rains. I am a research scientist and kind of a certified brain geek. I do a lot of consulting work with healthcare companies to help get a sense of whether their mental health and kind of mind-based health is rooted in what we know about the neuroscience of lots of these different kinds of conditions. So it's been very exciting. Neuroscience has really exploded in the last few years. We're getting a much better understanding of how the brain works. And most importantly, we're really getting a much better sense of how the brain and the body are connected and what those connections sort of look like and what they mean. And one of the richest areas that this has been very helpful in is in pain, particularly in chronic pain. Really quickly, I also want to point out, I am the chief scientific officer for a company called Healing Track, and I can kind of touch on that a little bit later, but that is a company that is built to digitize one of the therapies I'm going to talk about today called pain reprocessing therapy. But I am a friend to all brain-based therapies, and so I want to make sure that I let you guys know that, but I'll be talking about a lot of different kinds of therapies that have very similar mechanisms of action today. So go ahead and move to the next slide. And very quickly, we're going to go through a lot of information, but I want to keep it kind of simple. A lot of people hear neuroscience and they panic because it's one of those things that it's like, oh, this is going to be a lot of big words and pictures of the brain. There are a lot of pictures of the brain in my slides, but I promise I'm not going to go through and do a bunch of neuroanatomy. We'll talk about it at a level that hopefully makes sense to you, and you can get a sense of how some of these therapies work and why integrative therapies in general, particularly those that Dr. Claw just talked about, why they might work as well. It's just something that really becomes helpful as we're developing approaches to pain and doing these things, is to kind of get a sense of what are they doing to the brain, what are they doing to the body, because the answer is most certainly not nothing. So we'll talk about some of these new directions, what it's doing for brain therapy, and then some of the opportunities and challenges on those. Next slide. So a lot of people wonder, and maybe you guys don't, this is probably a much more informed group, but why is brain a pain issue, or pain a brain issue? In neuroscience, we have terms that we discuss for a lot of things. We call them bottom up and top down. They're types of signals. And in healthy people, pain is no different. It has bottom up and top down components. Next slide. In general, bottom up components are signals that come from your body and go to your brain. So when you're kind of going out there in the world, this is the stuff that navigates and helps your brain, which is locked in this dark skull of yours, to get a sense of what's going on around it. In pain, there's very specific signals, and they are called nociception. And you'll notice that that matches what Dan was just talking about. Nociceptive pain comes from when these nociceptors are activating and letting you know there's damage in your body, SOS, right? So they sound the alarm. Nociception itself actually doesn't really feel like anything, and that's something interesting. That's the next point. So next slide. There's a top-down component to pain, and when we think of pain, the feeling of pain, our experience of pain, that is the top-down signal that we're thinking of. So all pain, no matter what, whether it's nociceptive, whether it's neuropathic, whether it's nociplastic, or what I like to kind of just refer to as non-structural pain, it's a little easier to say, those are all living in the brain. Your brain is pushing that down as a top-down signal. And as a result, it has a lot of components that are much more complex than we've given it credit for in the past. So it has a lot to do, it's interconnected with other parts of your brain, so it's with memory and emotion and all kinds of things that go into your just general interactions with your environment. Next slide. One thing that is probably the most important aspect that's come out of research in recent years is that nociception and pain are related. So nociception goes up, it essentially it activates that pain response and then you feel the pain. In an ideal world, I guess that kind of little lateral explanation works, but they are actually independent processes. And since they are independent, nociception doesn't always cause pain, and pain doesn't always have to have nociception happen. Next slide. Probably one of the signature questions that's come out of chronic pain care, and speaks to a lot of the things that Dan mentioned, the updates in our thinking, really came from the question of traditionally, we thought of pain as there's something wrong in your body, we'll just fix it and the pain will go away. But when pain happens and there is no nociception, there is no damage, we don't see anything wrong, how do you fix it? What do we do? And a lot of times we still try and do bodily things. Traditionally it's hard to move on from the things, but in more recent years, as integrative care has become more well-known, as we've actually given a lot more, respect and guidance and awareness to these, what were traditionally called, complementary therapies, we're realizing they're not, like Dan said, they're not complementary. They're actually changing the parts of the brain that we need to target. And that's really exciting. So let's kind of jump into that on the next slide here. What is happening in the brain? So I have a little picture here. I know it's kind of hard to see, but kind of one of the things that we need to think about, that we need to target, is a little guy in your brain called your amygdala. You've probably heard that term before. The amygdala does a lot. It's an important cast member of the brain, but one of its biggest jobs is sort of seeking and kind of taking in signals and looking for threat. It's always kind of trying to keep you on the up and up. It's keeping you alive. And it wants to make sure that if it finds a threat, it remembers to avoid it in the future. We don't want to mess around with that. So it ties in a lot to that. Whenever the amygdala is connected to things, it tends to be a bit of a danger alarm. Not always, but that's a big part of its job. What's been really interesting is, as we've studied through fMRI, people who have chronic pain or non-structural pain, what we see is that connection between the amygdala and the pain processing centers is hyper connected. It's too strong, too fast, too much. So in healthy people, we see connectivity between the amygdala and pain. Of course, whenever something hurts you, you don't want to come around it anymore. That's a very normal response. However, whenever you experience something like trauma, the amygdala can go a little crazy and it starts to really panic and think, this was really dangerous. I almost died. So I need to really take into account everything that just happened. I want to predict it, and I want to make sure it never happens again. And some of the connections it can make as a result, particularly if the trauma was painful, but not always, it's going to make some really strong connections to the pain processing centers. It's important to note, and I don't want to get off scope, but Dr. Claw mentioned too that there's other things that kind of come into play here. We don't only just see pain, and that is most certainly the case. And a lot of that comes down to that hyperactive amygdala getting involved with the part of your brain called the insula, and starts to have kind of wreak havoc on a lot of your automatic processes. What's really interesting that I wanted to note to everybody is that in healthy folks, this connection between the amygdala and the processing centers is actually stronger naturally in women. It plays to a lot of really interesting adaptive features that we tend to see different performance rates between women and men. But it also could be a helpful factor to consider whenever we look at the folks who do suffer from chronic non-structural pain. Traditionally, there is a sex difference, and it's likely connected to the idea that women tend to make these amygdala connections a little bit more strongly, a little bit more frequently than men do. So, of course, there's lots of complexity to how chronic pain is developed, but that is one indicator that can kind of help to explain why we tend to see more of these conditions in women than men. Of course, it doesn't matter your sex, you are capable of developing these issues no matter what. So what does all this mean in English? It means that the brain has learned to associate danger, negative emotions, and pain. So whenever you're experiencing something negative in your environment, something that sets off that danger alarm that maybe is a little bit too sensitive, and Dan made a really good metaphor there, the volume is a little too high, the sensitivity is a little too high, then your brain will start to activate that pain response. So whenever stressful or scary situations occur, when you're experiencing negative emotions, even when you're not really conscious of it, maybe you're kind of suppressing them, you can have that same top-down pain signal activated, even without that nociception, but it is the exact same pain signal that nociception itself would activate. So in other words, I think it's very important for people to know that the pain you feel when you have brain pain or top-down pain or non-structural pain is the exact same as if you would have structural pain. And I don't know that that's always well known by providers in particular. This is the exact same pain. And I think that it's also not always well known by patients, and unfortunately drives stigma around non-structural pain. And there should be no stigma. This is the exact same feeling. So I really want to drive that home. Next slide, please. So let's talk about what this means for therapy. So luckily, there's been a lot of therapists who have been following this literature, their understanding, and they thought, hey, let's take a look at some therapies that target that connection between the amygdala and the rest of the brain. Let's see if we can kind of focus on that. So they're focusing on that top-down signaling rather than bottom-up. Now, certainly bottom-up signals can be changed too. So if you want to change some of the things that kind of contribute to your amygdala freaking out and kind of all those things that contribute to the danger alarm, you can do that. But sometimes there can be a lot of them and they can bounce around. Your amygdala can relearn through different signaling. So unfortunately, it can be a little bit tougher to do it that way. So focusing on the top-down signals has been a focus to get something that hits it from that other direction as well, to help make it extra effective and super efficient. The process to change these connections, particularly those amygdala connections that are related to fear and danger, is really similar. You could argue exactly the same as exposure therapy. Some of you guys may know exposure therapy is a therapy very commonly used by therapists to extinguish fears and phobias. So these brain-based techniques are reinforcing that the body is undamaged during pain-provoking situations to sort of help to reduce that sense of danger. And you have to do that very mindfully and really kind of get that in there. Go ahead, next slide. And this is also based on the assumption of neuroplasticity, which is relatively newish in the recent decades. We used to think that after the age of 20, 25, that your brain was stuck the way it was, that didn't change very much. That's very untrue. The brain is very flexible. It's always changing. And one of the philosophies of a lot of these therapies is that what can be learned can be unlearned. Next slide. Initial studies have been very promising. So we're seeing that a lot of these brain-based therapies do change the connections of the brain's pain centers. They've been shown to reduce that hyperconnectivity from the amygdala. They've also been shown to increase connectivity from the front part of our brain, the prefrontal cortex, which is sort of our logical brain, and that helps slow down that panic mode, that danger signal from the amygdala activation as well. And what's really great is on the back end, they do follow through and demonstrate dramatic pain relief for those who respond. So it's been very exciting so far. Next slide. So those of you might be thinking, oh, this is a perfect cure for pain. Fantastic, sign me up. Not so fast. It's not perfect. And I want to talk a little bit about some of those challenges that we're working on still. Next slide. So they don't address damage. It's very important to know that if you break your leg, you're not going to want to just immediately go for brain-based therapy. Dan did mention that a lot of people who do have damage in their bodies also have this kind of top-down pain as well, which is unfortunate. It'll elevate and can make the pain more intense, more frequent. Brain-based therapies are not going to address damage. And for exposure therapy to be most effective, it's ideal if there isn't structural damage in the body, because a lot of it is that you have to reinforce the belief that your body is safe, your body is fine, your body is undamaged. If you're being chased by a bear, it's okay to be afraid of a bear. So it's a little tough to do exposure therapy for a bear phobia if one is actually chasing you. So it can be a little difficult, but it is something to consider. That a lot of pain providers are seeing that a lot of chronic pain is non-structural. Even though historically we thought there might be some causes for it that were structural, we're seeing that those are actually just common signs of aging. So the more we're doing imaging studies of healthy people who don't struggle with pain, we see a lot of the similar issues that might be seen in imaging for chronic pain patients. So it's helping to lessen the evidence that a lot of those structural abnormalities are in fact damage that would cause intense pain. So something kind of interesting. Next slide, please. These are very new therapies and they are still being tested. So we've had very promising preliminary results and everyone is very excited about them. But with any new therapy, they're not going to have as much evidence as something that's been around like CBT. So when you're going through, you don't see as much of what we call replication, which is very important in science. Know that scientists like me and others are really focusing on replicating these as much as we can. We need to know how, really making sure it works the way we think it does, what are techniques we can do to make it even better, and probably most importantly, who responds to them and who doesn't, because they aren't perfect. And we would really like to get a sense of who can we recommend these to that we can really see a big difference really quickly, and who are not the greatest fit for these. So we're still learning a lot of those nuances in clinical applications. Next slide. And lastly, they can be difficult to access. Like any in-person therapy, there's not a lot of therapists. So that's one big thing that we're struggling, but also a lot of doctors have very limited training on the neuroscience behind these therapies. And so a lot of med schools, actually, I like to point out, have fewer hours on training for pain than vet schools. So it can be a little difficult, but there are many, many providers who are very anxious to learn. They're very excited about it. There's been some good press about some of these therapies. So a lot of people are working, and it's just going to take time, but there is a lot of interest and a lot of really great providers out there who are educating themselves and getting really caught up here. And there's a lot of training assistance. So we have folks who are out there trying to train on these therapies. Right now, insurance doesn't often cover these therapies yet because they are new, so costs can be prohibitive. What we are working on right now is working with insurance companies to help get that in there. The claims codes that Amy mentioned are very helpful for things like this. And we're also working on digitizing the therapies so that we can help to do this without the barrier of needing to have a human being there. Next slide. For those of you guys who are interested, I just threw in a couple of resources. You can learn more. There's a lot of brain-based therapies out there. So I did not cover all of them, but these are some of the bigger resources that are more common and kind of popular out there. Please don't take this as an exhaustive list. It's tiny, obviously, but just some of the ones that frankly, I've worked with. I know them and know that they've been working with neuroscience, but many, many people are out there. So you can check these books out. Curable is a wonderful resource, and I highly encourage anyone interested to check it out because you'll get a much better, much richer resource list there. There's so many people. There's also kind of a lot of terminology and names, so it's important. Next slide. These are all just the references. So if anybody's interested in reading more, please do. I apologize, I went over a little bit. So I will cut it short there.
Thank you, Dr. Rains. Just in interest of time, I'm going to jump ahead and introduce Dr. Prasad. So he is clinical professor and director of behavioral health in the Department of Anesthesiology and Pain Medicine at UC Davis. So turning it over to you now.
All right, thank you very much, Amy. So I'm going to start off. We can go ahead and start the slide with the one pain in context. I'm going to start off by looking at pain from a 30,000 foot perspective. So next slide. We'll just kind of start looking at pain in the grand scheme of things. So U.S. Department of Health and Human Services estimates that roughly 20% of the U.S. population has chronic pain. And of these individuals, just over a third have what's called high impact chronic pain. And this is chronic pain that has been persistent for more than 3 months and results in significant impact in at least one domain of a person's life. Pain tends to be most prevalent in women, individuals over the age of 65, and non-Hispanic white adults. And pain tends to be most prevalent in the rural areas. Next slide. As Dan mentioned, of course, one of the primary goals that we have is to try to treat the pain itself as much as possible. You know, it stands to reason that the less pain a person has, the less suffering that a person will have. But even with the best treatments, we may not be able to eradicate pain completely. And so in those different types of situations, the goal of the clinicians who are working with individuals living with pain is to help them manage their pain as best as possible. But when I mention this to folks, managing pain, living with pain, clinicians who aren't working in the pain field and patients, payers, they all have a hard time sometimes grasping what exactly does this mean, learning to live with pain. Next slide, please. So let's say that this square represents your life. You go to a family reunion or you sit next to somebody in an airplane and they ask you about your life. What are the things that we talk about? Next slide, please. Oftentimes we talk about all the things that fill our life. We talk about our family, our friends, work, school, vacations, even the more mundane things in our life, our chores, our errands, because these are the things that give us quality of life. But one day a pain condition sets in. Next slide. And it takes center stage. It's something new. By definition, it's something that's acute. And we go through the regular process of trying to get it worked up. What is this? We try to get it treated because we want to eradicate it. But even though this pain condition is present, we still have space in our lives for all the things that give us meaning. But over the course of time, as this pain condition fails to respond to initial treatments, it starts to radiate out as it becomes chronic. Next slide. And as that happens, we start to see a number of different impacts. We start to see decreased activity levels. People start to pull away from family activities. We start to see increased work absenteeism. We can start to see increased affective distress, depression, anxiety, frustration, anger. And that can either be like clinical level, clinical depression, clinical anxiety, or just as we define those words in the dictionary. Sleep disturbances can start to come about, where a person has difficulty falling asleep, difficulty staying asleep, or difficulty getting a restful night's sleep. And that can be because of the physical pain they have. It can be because of the affective distress. It can be because of the medications or the treatment that they're receiving for the pain or affective distress, or because of a combination of all those things. Individuals oftentimes have more doctor office visits. It's not uncommon for us to hear patients say that the most significant physical activity that they have is when they go to their medical visits, or the most significant social interaction they have is when they go to doctor offices. And all of this can start to lead to problems in their interpersonal relationships. It makes sense that as people have a higher level of affective distress, as they have decreased activity levels, pulling away from their life activities, that they may start to have conflicts, conflicts with family members, conflicts with significant others, with their employers. And then ultimately, pulling away from activities, not being as active, can lead to physical deconditioning within the body. And then as people try to start to move and do other activities as they become deconditioned, everything can start to hurt. And this compounds the physical pain problem. And so now you ask a person who's living with pain about their lives, and many times what you may hear are conversations about a different drug that they're trying, a new clinician that they're meeting, a new center that they heard about that may hold a lot of promise to try to help them. And as you listen, you no longer hear the person telling the story about their life. You hear them telling the story about the pain's life. And even for a person who's living in pain who doesn't do this, this may be part of the thinking process that comes up in their mind at some level. And again, it's no longer telling the story of their life, but the pain's life. But it's easy to understand how this transition occurs as that pain becomes chronic, because it starts to radiate out and overshadow all those things that give a person's life meaning. So the primary goal of the clinical management of pain, of helping individuals learn to live with pain, once we've maximized the relief part of what we can do, is to maximize functioning. Next slide, please. Maximize functioning, maximize quality of life. We may not be able to eradicate 100% of that pain, but if we can eliminate a lot of the distress caused by the pain and decentralize a role of pain in a person's life, that gives them space to re-engage with the things that give them meaning. Now, accomplishing this is not something that's easy to do, right? Next slide, please. If pain was a simple cause and effect relationship, then yes, there may be a simple procedure that we might be able to do. There may be a simple medication that we could prescribe that would just allow this to happen. But the reality is pain is just a skosh more complex. Next slide, please. And the relationship between cause and effect is probably something that looks a little bit more like this. This was a diagram that was created by my colleague, Dr. Ming Cao, the clinic chief at Stanford. And it depicts kind of the complex bidirectional relationships among all the different biological, psychological, biomechanical factors, and how these things influence the presentation of pain. And even this, Dr. Cao, when he created this years ago, he says, I have updates to this. This isn't comprehensive enough. And it isn't, because there's so many different factors that influence, again, that experience of pain. And so as a result, getting to that place where pain is decentralized and people have space for quality of life isn't going to be a quick fix. And it's going to require multiple interventions in multiple spaces. Next slide, please. Next slide, please. So how do we get to that? Well, earlier on in her presentation, when Amy introduced the group here, you saw this wheel, and it illustrates the multitude of different interventions that are available in a truly integrated fashion, the comprehensive set of tools that are available for integrative pain management. And each individual person living with pain is going to require their own combination of these to help get to that point where their pain is optimally managed. No two people are alike, and so therefore no two treatment programs are going to be exactly the same. It should be individual specific. As a psychologist, I'm a full-time psychologist in the clinical domain. And so this is what I do clinically every single day. I'm going to speak to you very quickly about what we do from a behavioral perspective. And I'm not going to dive into the weeds with this, but just speak about it from a very broad perspective. Next slide, please. Cognitive behavioral therapy has long been regarded as the gold standard in behavioral management of pain. And there are three primary components with CBT for pain: helping patients understand how their thoughts and behaviors can influence their experience of pain and their ability to impact this relationship, that they're not helpless to influence this. But the key thing is, this isn't saying the pain is all in your head, you're making this up, but more you have the power to influence the overall experience. Teaching patients coping strategies to influence this, but most importantly, helping them learn how to apply it. There's a big difference between knowing and doing, and it's that doing part that helps achieve the outcomes. And so helping patients understand that and overcome obstacles to putting this into practice. Next slide, please. So there's a wealth of evidence that supports evidence-based or CBT interventions for pain. Linton and Anderson had patients with low back pain participate in CBT-based interventions versus minimal treatment and followed them at 12 months and found that the risk of long-term sick leave or long-term disability decreased significantly in the patients who had CBT, and the CBT group had less medical utilization compared to the regular treatment group. Now, this is an old study, but the reason why I like it is because they did a 5-year follow-up. Next slide, please. And they had pretty good representation. 97% of the people completed the follow-up questionnaire, and they found that the CBT participants still had significantly reduced likelihood of going on long-term disability. They also had less pain, higher activity, better quality of life, and better general health compared to the minimal treatment group. So we're seeing pretty strong evidence for the use of CBT. And in other studies, next slide, please, clinicians have used CBT-based interventions as a part of a multidisciplinary program to help patients successfully reduce their use of opiate medications. And this study, as well as the next slide, illustrate some larger studies that have demonstrated the efficacy, next slide, please, of CBT-based interventions to help patients with reducing opiate medications. And we heard our last speaker speak about neuroplasticity. Both of our speakers have spoken about brain changes. And it's important to recognize that with CBT, we're not just modifying thought processes to influence our behaviors, but this is actually associated with changes in the brain. Next slide, please. Imaging studies have shown that CBT, when patients are applying this, it does result in changes in different regions within the brain. Next slide, please. And these are some of the different regions of the brain where we see either structural changes or functional changes when people are engaged with CBT. Next slide, please. And studies were done to look and see, is it just the education piece or is there something unique with CBT that's causing this? And what we've actually found is it's the CBT itself, not just education. So that gets back to what I was saying before about the difference between knowing and doing. Next slide, please. Now, I spent a lot of time talking about CBT, well, not a lot of time. I spent a bit of time talking about CBT in my section, but I want to emphasize that that's not the only evidence-based treatment for pain. Next slide, please. There's a wide range of other psychological treatments that have robust evidence base behind them: acceptance and commitment therapy, mindfulness-based interventions, emotional awareness and expression therapy, and biofeedback. And we utilize whichever one is most appropriate for the patient, again, in an individualized treatment plan. Next slide, please. Many times individuals will read different studies and they'll see things that are done in a scientific manner and they say, but what are the real world applications of this? Does this work in the real world? Does this work where people need to get paid for their services? And I can say it absolutely does. As I mentioned, I'm a full-time clinician, and at UC Davis, we've put these things into practice. In our clinic itself, we have an interdisciplinary group of specialists. We have physicians that represent physical medicine, anesthesiology. We have nurses. We have licensed clinical social worker, myself, I'm a psychologist, we have acupuncturists. We all work together to try to accomplish this, but we also collaborate with other departments within our medical center, with neurology, with oncology, with primary care to try to help patients have a comprehensive set of tools to manage their pain. We recognize that we can't have all these things within our group itself, and so that's why we network to try to leverage the resources within the medical center to help to advantage our patients. We've recently developed an integrative medicine program as well. We have an integrative medicine department that was just started at UCD around the time of the pandemic. And so they're also starting to formulate their own identity, and they're slowly starting to grow within our center. Next slide, please. And what the pandemic also had us do is we expanded into telehealth. All of us got a crash course in telehealth, which has allowed us to expand our clinical reach, which was great. But the downside is what we realized is it's not the cure-all that everybody thought it might be. It introduced a lot of disparities in care, a lot of things where we realized that patients may not have access to. Their financial disparities were, for example, paying for cell phone plans, paying for data. These things are not accessible for many patients. And so as we come up with our treatment plans, we don't only need to think about what types of treatments are most effective for patients, but what's accessible for patients, and making sure that we devise treatment pathways that work for the person with whom we're working. Next slide, please. So in conclusion, treatments for chronic pain focus on maximizing function and quality of life. There's a wide range of evidence-based psychological treatments. But pain itself is a multifactorial experience, so we really need to employ a truly integrated interdisciplinary approach to maximize outcomes. And it's really important for all members of the treatment team to reinforce the approaches being used by their colleagues to maximize and promote the engagement by the patients. So that was a very quick overview, but thank you all for your time.
Thank you so much, Ravi, and that was terrific. And now we are going to move to Keaton Schmitz, and I'm excited to introduce Keaton. She is a third-year medical student and a person living with fibromyalgia, and she's going to share her story and experience with us today. So I will turn it over to Keaton.
Hello, I'm Keaton Schmitz, and as Amy mentioned, I'm a third-year medical student at OUWB School of Medicine in Michigan, and I am also a fibromyalgia patient. Next slide, please. So just an agenda, we'll go over my patient history, including past medical history, social history, history of present illness. And then the second part, we'll go over problems encountered in care and possible solutions, including under treatment, mistrust, and lack of knowledge. Next. So past medical history. So I was born and raised in Heartland, Wisconsin, and I had a very active, fun childhood full of lots of love and just great times. I was, however, accident prone, broken leg, 12 double stitches in the other one, glued forehead, burns, scrapes, cuts, you name it. I probably did it. Next slide, please. And I ended up going to the University of Alabama for undergrad. I studied chemical engineering there, so a little bit of a different route, but I knew I wanted medicine. I just wasn't sure if I wanted research or if I wanted to be involved in patient care. And through my time at the University of Alabama, I decided that I really loved patient care and ended up pursuing medicine, and that's how I'm now studying to become a physician. So hobbies I picked up along the way, I really got into running in college. I ran 3 half marathons, and I also really love hiking. It was something that I could do with friends and family, and I just love being out in nature. It's super peaceful. And I also really got into my faith. I didn't honestly have one prior to college, but I asked tough questions and fell in love with my faith. Next slide. History of present illness. Next. So in the October of 2020, I started experience 2-week period of a flu-like illness. I just had nausea and headache and slight body aches, like maybe I wasn't recovering from my workouts or something. And then one night I just got smacked out of nowhere. Like a semi truck hit me with excruciating pain. I was up all night and didn't sleep. And I unfortunately have not been able to return to my healthy, pain-free self since. It wasn't until August of 2021, however, that I received the fibromyalgia diagnosis. Next. Chief complaint, muscular pain. How do you describe this pain? Next. Widespread in my limbs and my upper back. It's really hard to describe and accurately depict the pain that I experience being widespread, but I believe that a picture paints 1,000 words. And if I were to use a picture to describe it, this would be that picture. Next. So putting, as I said, it into words is really hard, but I've read so many books since I got sick. And one patient put it very poignantly when she said that it feels like every morning she wakes up as if she had been hit all over her body by a baseball bat. Next slide. Life effects of the chief complaint and pertinent positive symptoms. So it's really, pain really affects everything. It affects everything in your life, your ability to work. For me, that's being a student. And when you're a medical student, you are studying on a pretty tight schedule. You kind of have to plan your off days. But unfortunately, my off days couldn't be planned. They instead had to be the days where I was just in too much pain that I could not function. And instead of going out and doing fun things with my medical school friends, my off days were spent alone, writhing in pain. It impairs your activities of daily living and leisure. So just doing things around the house, it feels like I'm walking through mud. Like it's just so much harder when you have to fight through pain to do it. And your leisurely activities, the things that once brought you joy, you can't do anymore. For me, running, I loved it. I loved the endorphin high, the mental clarity. I loved being outside, and I can't do that anymore because it makes my pain so much worse. And then a huge thing is sleep. Sleep and pain go hand in hand, and they kind of become a vicious cycle. More pain equals less sleep, but less sleep equals more pain, and round and round and round it goes. And an interesting study on fibromyalgia patients actually found that we get less stage 3 deep restorative sleep. In 1975, a study was done on healthy college students where they found they could actually induce what they termed fibrositis syndrome, so pain similar to fibromyalgia throughout the body, by depriving them of sleep. Next slide, please. So problems and solutions for current treatment. So a huge thing is undertreatment. I walk into clinics and I always walk out feeling disheartened and unhelped. I usually get maybe 1 to 2 pain medications, and that's it. That's the answer they give a 24-year-old who doesn't understand why on earth she is experiencing pain over her entire body. And I really have had to kind of advocate for myself. I have had to become my own care coordinator and do the research to find integrated and complementary treatment options. And it's sad that this isn't provided. It needs to be kind of automatic that integrated care teams exist for pain patients. Next slide. So I've tried so many different treatment options myself. It actually is kind of exhausting sometimes, but there's a few that I found to be pretty effective for me. And everybody is different. And so what works for me isn't necessarily going to work for everyone else, but I will just elaborate here on 5 of the ones that I did find super helpful. So lavender essential oil, I will just diffuse it in the air while I study or while I'm trying to go to sleep. The linol component of lavender oil is actually found to act on SERT receptors, so increasing serotonin. It also acts on GABA receptors, having mechanisms similar to like gabapentin or Lyrica. So really strange when I first started experiencing the effects. I was like, why is this helping me? I did the research, but myofascial therapy, that's one that I actually read was really helpful from a book. And it is just a specialized form of like massage therapy where the therapist actually works on getting rid of fascial restrictions. And in fibromyalgia patients, a study in 2020 found that we actually have higher levels of pressure within our muscular compartments. And so it makes sense that trying to release some of these restrictions and releasing pressure can then really reduce pain. I've also found infrared heated yoga to be super helpful. I have tried so many different types of exercise to get my body moving again, because I still love to move my body. And this is the only form of movement that I find not only doesn't hurt me, but actually helps with the pain. And I like the infrared heated component because studies have shown actually on photobiomodulation therapy with lights in the infrared spectrum that it can decrease time to fatigability in athletes. And it actually has decreased markers of inflammation, creatine kinase, lactate dehydrogenase within the muscle tissue. Mentality, and emotions, I really do believe in mind-body connection, and it's really important to have that incorporated into care in some form or another. Pain affects everything, and one of the biggest things it affects is hope. You can just feel so hopeless. You're trying everything in your power just to fight through the days, everything in your power to get out of pain. I don't want to live in pain the rest of my life. I'm 24 years old. I want a future where I don't have to fight through pain. And so it can be super discouraging and frustrating when you're fighting and you're not getting out of pain. And so finding an avenue to be able to find that hope again is super important. And for me, that's been my faith. Prayer has been super important for me. I also have started to meditate, and I found that helpful as well. And then the last thing I just wanted to elaborate on is a vagal nerve stimulator. Anyone in pain and is going to be in a fight or flight state. They're on high alert. And the vagal nerve stimulator, you just put little earbuds in, and it stimulates a branch of the vagus nerve in your left ear with just electrical pulsations. And it helps me sleep, and then better sleep equals less pain. Next slide, please. So a huge problem too within medical care is mistrust. I don't trust the medical field as a patient, even though I want to enter it as a physician myself. I don't feel validated often. It's an invisible illness, and I recognize that. I recognize that it's hard for you to understand what I'm going through, but I still need you to validate me and not dismiss me. I want us to address pain and functionality goals. I think that this would be really important. Instead of just receiving the pain medications and sending me on my way, ask me, because I'm not always willing to share how this is affecting me. I want you to ask me, how is this affecting your function? And what can we do to improve it? I want short-term goals. I want long-term goals. I need a gauge for how we can improve my pain over time. And then be aware of unconscious bias. It occurs in so many different avenues. And interestingly, in a 2012 NIH study found that patients who use complementary treatment options, 42% don't disclose that to their practitioners. And I am one of those 42%. I don't disclose that. I kind of become the director of my own care. I don't want my care to be clouded by bias. And so I go to my primary and I ask for pharmaceuticals because I know that's what they're going to give me. I go to someone else who's going to help me with supplements. I go and I direct my care with yoga. I direct my care with my chiropractor. I have to be my own care coordinator. And it's kind of sad, though, that I have to do that because I can't imagine how hard it is for someone who doesn't necessarily have the background knowledge that I do to be able to coordinate their care and help themselves manage their pain. And so I think just having these integrated care teams as a default would be super helpful for patients in pain. And then the last thing I really wanted to talk on was lack of knowledge. The medical education on pain is just lacking. Next slide, please. So in my entire first 2 years of medical school, I did not receive one slide on fibromyalgia, not one slide educating me on the pathogenesis or treatment. The only education I got on my disease that has impacted my life in ways that you cannot even begin to imagine. I got 2 sentences out of an outside resource called First Aid, which is a preparatory book for your Step 1 exam. 2 sentences, that's all I got. A study in 2011 by the American Pain Society found that of 104 US medical schools, only 4 required having a pain course, 4 out of 104. And only 17 of 104 medical schools offered a pain elective. And when you take into account the fact that 1 in 5 Americans suffer from chronic pain, there's a huge discrepancy and a huge gap that needs to be fixed in medical education. Next slide. And that's kind of just the little overview that I have. I'm happy to take questions.
Keaton, thank you so much. This was a really moving piece, and I appreciate you sharing your story. We're going to do questions here at the end. We have one more presenter. So I am now, oh, did you want to make a comment on this?
You're good. That was just a kind of a hopeful little song that I love to listen to. So got good words of encouragement.
Yes, thank you. Incited works. So now, and I know we are we're running a little behind because all our presenters have so much valuable information, and so we're going to still try to squeeze in as much Q&A as we can. I would now like to turn it over to Dr. Nicole Golding, and she is the medical director, health services for American Specialty Health. Nicole.
Yes. Hi, Amy. Thank you so much for having me at this webinar. Can you hear me? Yes. Okay. So my name is Dr. Nicole Golding. I'm Medical Director of Health Services at American Specialty Health. And we're a 35-year-old company that's a health benefits and health insurance company. I want to try to tie my talk back to the HS toolbox and that great slide that Amy pulled up. You'll see how we incorporate biopsychosocial aspects into our programs because patient-centered care is such an important topic and we're constantly talking about this. In a few minutes, I'm going to share an example of this program that we put together for a health plan to provide integrative medicine insurance benefits and show how we also use patient advocacy to implement a person-centered program. But before I get into that, I wanted to share what American Specialty Health does and why health plans work with us. Next slide. So we have many aspects to our company, but the first is our specialty networks. If you look over on the left-hand side, we have a network of 92,000 contracted providers across 50 states in the following integrative areas of treatment. So chiropractic, physical therapy, virtual physical therapy and rehabilitation, also acupuncture, therapeutic massage, that should read therapeutic massage there, as well as naturopathy. And it's one thing to have a network of integrative providers, but it's another to have high net promoter scores and also accreditations. And you can see we're NCQA and also URAC accredited, as well as our net provider score and working with our health plans, which are over 250, is 70, which is very high. Next slide, please. So it's also, as far as having a network of integrative providers, it's very important to have a high level of clinical outcomes and high patient satisfaction. So we did a survey. We asked, was the ASH practitioner successful in treating your primary condition? And you can see for all of our integrative programs, chiropractic, acupuncture, massage therapy, it's all over 90th percentile. Also through CAP survey, we found that there was a 98% patient satisfaction rate and 94% felt that they received all the care that they needed. Next slide. We also do clinical coaching. We've been coaching for over 17 years. And these are some results of a program we put together, and we looked at member satisfaction and also our net promoter score. We incorporated both a digital and live coaching aspects, and 95% of members were satisfied with the program and a net promoter score of 57. I keep putting the net promoter score because it's a measure of customer satisfaction and whether you would recommend this company to others. And along the bottom are other numbers for comparison. Next slide. So the reason I put up this slide is because we published the data, and the reference is cited in the right upper hand corner for those who would like more information. I'm not going to go over this case study from that group. I'm just going to move on, and we'll talk more about other case studies in a minute. Next slide. So part of our program is navigation coaching. And it's really important because they educate our members on the different integrative therapies that are available. They also help with logistics, scheduling, website access, also educate about cognitive behavioral coaching and the value of learning new ways to address pain, and just provide support for any barriers with our overall program. Next slide. Next slide. Thank you. And so this is a slide about our cognitive behavioral coaching that is performed with a nurse coach. The cognitive behavioral coaching focuses on what motivates and educates individuals about the connection between thoughts and actions, and helps participants develop new behaviors and reframe thinking to approach their recovery and functional activity in a more effective manner. And we focus on 6 domains. They are being active, getting motivated and taking action, understanding your options, also reframing how you think about the pain, what is the pain telling you and how you respond to it, and then taking care of you. What does self-care mean? What can I do to help myself deal with my pain? And then lastly, getting the help you need. And this maximizes the doctor-patient relationship and allows members to take ownership of their care plans. I find that this last part is very important because helping members and patients learn what kinds of questions they need to ask to get the kinds of answers that they want is very helpful in facilitating discussion about their diagnosis, treatment options, understanding what their doctor wants them to do about their exercise and self-care. And even though they may not get all the answers they need, it just maximizes that relationship, and it might lead to referrals, further discussions, further research, just improved communication. And some of that validation that Keaton was talking about as well. Next slide. So this is the social aspect that we focus on. Quality assurance through a multidisciplinary team is key because it really addresses issues that we find in complex cases, particularly when they're social determinant of health issues. We want to facilitate alerting external referrals, particularly case management at health plans, so that additional help can be provided. Health plans want to know about these kinds of problems, and we provide an easy conduit to get them this vital information. And then in turn, patients receive a comprehensive approach to their overall health picture, not just their pain. And so we're able to coalesce all the resources that are available to patients, but they might not be able to access themselves easily. And part of this is also our extensive online resource library so that they can read about so many different conditions, what kinds of therapies are evidence-based, and just have a point of discussion for all of their providers. Next slide. So this is the program that we developed with a health plan. I wanted to get into it specifically because there were many interesting components. One is that it was a Medicaid population. They were all on opioids and they had chronic low back pain. We did learn along the way that it would be better to open it to anyone, no matter what medications they were on or what location of musculoskeletal pain they had. So the way the program worked is that the health plan would refer into our program through a healthcare provider or through health plan case management. Then the member would talk to the navigation coach who would help with choosing an integrative provider, explain the program, and also schedule with a nurse coach. The network providers in this case were chiropractic, acupuncture, therapeutic massage, and we did also the medical necessity review on those networks. Next, they were referred into the nurse pain management coaching program, where they use cognitive behavioral coaching to address their pain, also lifestyle modifications, and assign or talk about the educational resources and have a discussion about it. Lastly, the component of the quality assurance is important for medical oversight and referrals to case management as needed to the health plan. Next slide. So it's a lot more complicated than I just described. This is actually a visual that we use with one of our health plans when we're working on implementation. But the key thing is that we really focus on the person. The green person there in the slide is the key in trying to figure out how can we coalesce all of the different processes. Next slide. So I want to go over 2 case studies. This is the first one. It's a 66-year-old female who had low back pain, a history of drug addiction, wanting to avoid alcohol and tramadol. She used a walker and was currently just using ibuprofen, and she really wanted to be able to still take care of her 2 dogs. Some of the issues is that she actually didn't want to get into coaching, but after speaking with the navigator coach, she did try it out and it worked quite well for her. She actually wasn't on opioids. So initially she had trouble getting into the program. We did get her into the program, obviously. She talked about how her friends wanted her to go ask for opioids and then sell them to her. She refused. She didn't want to be a part of the addiction cycle. And she also had a spinal stimulator that was hurting her. So in discussions with the coaches, she chose acupuncture. She found it very helpful. It felt like it was getting to the root of her pain. Simultaneously, the coach was championing her and staying off of alcohol. They helped set her up with acupuncture. There were some access issues that we worked out with the network to find one that was very close to her that she could get to. And we talked about finding more helpful ways to deal with her low back pain. A lot of this is member driven. So we're listening to what their lives are like, what is going on with them. And then we bring up appropriate topics. So for her, it was pacing, ergonomics, spine sparing movements, and opioid management. She actually was talking about how she would carry her dog around, and there were a lot of discussions about how maybe this wasn't the best thing for her chronic low back pain. We also focused on helping her talk to her providers and ask questions. And we also referred her to the health plan case manager. So on the right-hand side, we talk about the self-advocacy piece and how the case manager also helped. This patient actually restarted physical therapy and she started exercising. In all the talks about how to talk to her providers, she was able to get an appointment with the pain specialist. She talked with her physical therapist about writing a note about the problems with the stimulator so her pain specialist would understand right away. She got motivated to schedule with her primary care doctor because she had hypertension problems in the past. She was actually given a blood pressure machine and she found that her blood pressure was running normal, which was a great relief to her. And she also obtained a new walker through the health plan. She didn't know how to do it and hers was faulty. She started visualizing the future. She was talking about walking her dogs on the beach. She's had her spinal stimulator surgery scheduled, and she was thinking about getting a part-time job. She felt more optimistic and she felt like she was getting stronger. And this was achieved in about 3 months over just 5 sessions. Next slide. This is also a really interesting case study. 42-year-old with low back pain, radiculopathy, leg pain, and schizophrenia on oxycodone. So complicated. She was on welfare, on food stamps. She used to be part of a commercial weight loss program. She stopped due to the costs. She had a lot of issues where pain was affecting her mood. She was uncomfortable making appointments independently. So her case manager was having to do this. She thought her mind would be going blank whenever she would try to help herself and with all of her pain issues and her scheduling. And she was very stressed out about her doctor not prescribing additional pain meds. She wanted to lose weight and she was worried about other areas of pain in her body. So she decided to go with chiropractic treatment, and it helped both her shoulder and her low back pain, and both were better over time. And the coach championed her in her goals, and weight loss was a major one and helped her remember the point system and incorporate it from her commercial weight loss program. She really latched on to one of the articles she read on our website about inflammatory foods. She felt that reducing a lot of foods and changing her lifestyle helped a lot. They brainstormed on how to feel full, drinking more water, talked about mindful movement, abdominal core bracing. She watched videos and asked questions. They set up SMART goals for sleep and defined what self-care meant for her to help her deal with her pain. So the self-advocacy part was that she learned how to talk to her doctor, or they practiced questions. She did want to get referred to a pain specialist. He did not. Instead, he prescribed new medicines and they didn't work. And then we had to go back to the drawing board and talk about, have her talk about, if she wanted to talk about how they didn't work for her. And so she prepared for her different medical visits, discussing sleep, walking, how far she could walk safely, red flags. And another topic was her accessing all of her providers to ask them what would they suggest to work on mood. And she came up with listening to certain music. And one really important aspect was that she wanted to talk to her family about how to support her diet. And the coach helped her with that and asking questions and discussions. The case manager was alerted because there were financial barriers to the cost of healthy food. And she ended up obtaining a new care manager that she felt that she connected with better. Overall, during the time, she lost 3 to 5 pounds. She felt like she had a strategy to cope with her low back pain when it flared, and she actually stopped using her oxycodone. Next slide. This is my final slide. I think the key here is that a person-centered approach is not just integrative therapies, but also an integrated system. Can the program flex to address the person where they are on their journey? And expectation management is a big deal, because when you're designing something on a whiteboard and then trying to implement it, we found that the difference is really in how flexible and adaptable the staff and processes are in pivoting, how well you can share information with patients, making sure you have those contractual connections to share personal health information, and addressing all the aspects of biopsychosocial factors. Complex patients and populations are messy, and they all need help with self-advocacy, self-management, and also system advocacy. That's where we did also come in, not only on the coaching for the first 3, but through our multidisciplinary team in being able to access case managers to, some people need basic living support for social situations, but some also need medical support while addressing their pain. So integrative pain management solution provides complementary medicine specialties, but also educates about pain and lifestyle, changing perspective and reframing, as well as identifying significant medical management opportunities. And lastly, our goal was to drive a great outcome, and we learned that patient-centered integrated program demands effective integrated care for all of a person's health concerns, including providing a safety net. And it isn't easy, but it is possible. Thank you. That concludes my presentation.
Thank you so much. This was excellent. And we have had such great speakers. I know we don't have a lot of time for Q&A, but there are some excellent questions that have come in. So let me just quickly say, if all the presenters can put their video back on, please. And I am going to, okay. Stop sharing. And we have two things. We will get to as many questions as we can quickly, but if any of the presenters would like to type answers to any of these questions, please feel free, because we clearly won't have time to get to all of them. And I do just want to kick off one quick question that came, and this is to Dan and anyone else, but I just want to address the term catastrophizing, in the sense, I know that was in a number of your slides when you were speaking. And I know when you and I spoke before this webinar, we both agreed that that is a horrible term that we don't want to really continue. It has a lot of stigma to it. And certainly from the perspective of people with pain, it's something that many of us are trying to get rid of, frankly. And so I just wanted to kind of mention that. I realize it's sort of a question, sort of a comment, just in case you had anything you'd like to add to that.
I don't really have much to add. I think, again, just taking on scientifically the notion that this is sort of a trait that people have that puts them at risk of developing chronic pain, that's just wrong. It's really a lot more of a state. It can change rapidly if you make someone's pain better. And I just think, and again, there actually have been, in the pain field, there were a lot of interventions 5, 10, 15 years ago, aimed at reducing catastrophizing, acting as though that was like the critical path towards, and almost all of them failed to show any effect in chronic pain patients. And catastrophizing is probably playing a little bit bigger role in acute pain, actually, than it is in chronic pain as far as causal role. So again, I think a lot of this is just trying to use science and data to help move the field forward and get people to, stop thinking about pain in ways that are just inaccurate.
Great. Yeah. Thank you. Thank you, Dan. Okay. I'm trying to, it looks like there is a question here. Is your opinion, should every person with pain see a psychologist? Many refuse, and there's more to it. Do you think that, do we think that this is important for every patient? Does anyone want to answer that?
That sounds like a good question for me.
Yes.
So I'll take that one. I'm just a skosh biased, but I think that everybody would benefit from, all patients would benefit from seeing a pain psychologist. But I think a lot of it has to do with how it's presented to them. I think there's a stigma associated with seeing a psychologist, whether a person has a pain condition or not. But especially when somebody's living with pain, there can be this perception that, oh, you think this is all in my head. You think that I'm imagining this. It can be a sense of invalidation of the experience of pain. And so I think a big part of it is how it's presented to the person. And so explaining that we understand that pain takes a toll on your life, and commenting on that, those bidirectional relationships. As was mentioned, pain affects sleep, pain affects your activity patterns, it affects the different domains of your life, and helping you learn how you can influence those things, because as it affects those areas in turn affect your pain. And so helping you learn how you can navigate those is where having an evaluation with a psychologist can be helpful. And so a lot of it is in just the verbiage that's used to introduce it to patients. At our center, what we started to do is, as much as we're able to, we try to have all patients who are coming in have a pain psychology evaluation as well. I've done a lot of training with our physicians on how to do that discussion with the patients. But in many cases, I may be the first person that a patient sees when they come into the clinic. And so you can imagine that may be something, because it's just a part of our evaluation process. Somebody has physical pain, and the first person they see in the pain clinic is a psychologist. And you might imagine that could be something very disheartening for patients. That, wait a second, I've got real back pain. I had a physical injury. Why am I seeing you first? But I have yet to have any patient complain about it. And at the end of the visit, they say, this was great. I'm so glad that you guys do it the way that you do it. I'm looking forward to meeting Dr. Mahajan later on, but this was great. I love the way you all approach pain. So I have yet to hear a single complaint from a patient from the approach that we take.
Thank you.
Would patients benefit? Yes. If they don't, there are other resources available. Sorry. Okay.
Oh, that's okay. I'm sorry. I apologize. I thought there was a pause there. Nope. I'm noticing that because we really are at the end of our time, and I'm so sorry, we had really had better plans to leave more Q&A time. We can get answers to the people that send in questions, but I do want to give each of the presenters a chance, if they can take about 30 seconds, and please 30 seconds or less. And just we are all change agents in our own right. Each of you are doing things and hoping to see something better than what you have been seeing or seeing now. I'd love to hear just a couple words about where you think change agent efforts are most important, or something that you personally are planning to focus on in the coming year. Keaton?
Yeah, so I think that we just need to increase undergraduate medical education and other healthcare professionals, their education on why and how to treat pain. We need to include education regarding the burden of pain in the healthcare system, and then also its effect on the individual, and do better to remove biases against chronic pain sufferers, and educate people on the pathogenesis and how to better treat chronic pain.
Fabulous. I'll work with you on all those things. Okay, Bethany?
Access is big for me. We have some really cool, promising therapies. They're based on some really exciting new evidence, but right now, a lot of it is coming from one-to-one therapists. There's a lot of really awesome people out there that are working on it, but the more that we can find out how we can use technology and how we can use existing systems to get out there and get this to as many people as possible, that's my biggest passion in the coming years.
Fabulous. Me too. Nicole?
I think the most important issue is also access and evidence-based insurance coverage, just from my perspective. And I think you should ask your health plan to cover integrative therapies, including those that have coaching help. Communicate with them. They're listening. And a lot of health plans don't know how to do this. Our company, American Specialty Health, does. We've done it for 35 years in one way or another. And so if the health plans say it's too expensive or too difficult to incorporate, you can tell them that there's companies that are able to help them, and it's being done all over the country.
Fabulous. Thank you. Dan?
I agree, access. I think that's the biggest problem.
Yes. And Ravi?
Access to reimbursement. I think that's a common theme, and I'm actively working with APA from that perspective to try to work and help improve it.
Well, access certainly sounds like a unifying piece here, and that is the focus of so much of all of our work. And so I want to thank all of the presenters again for taking the time and the effort to put your slides together, and the passion and care you do in your work every single day. I will follow up and look forward to thinking of what else we can do with this information as we share it and expand on it. And to all of you who kind of hung in here till the last minute, thank you all for participating. Please do send in any chat, examples of things that you would like to see in future webinars, things that you wish had been a part of this presentation as well. We know there's many things we could have done, so we're open to your thoughts, and we'd love to hear from you. And we wish all of you a wonderful rest of your day. Thank you so much.